Morning, we are going to look at indirect ophthalmoscopy today. This instrument is an essential tool for the ophthalmologist, especially the retina surgeon, because the examination of the retina is not complete without an indirect ophthalmoscopy. The direct ophthalmoscope that we used to use in those days, we only see the central retina, the optic disc and the macula. But the indirect will see all aspects of the retina up to the periphery. And unfortunately, most of the condition of the eye, of the retina, occurs in the periphery. So it is better for you to have your own personal indirect ophthalmoscope if you must enjoy examining the retina. So today we'll look at practical steps. The first step, because in the exam, those are the steps that we look out for you to be able to identify the parts of this indirect ophthalmoscope. This is the illumination area. This is the wireless indirect ophthalmoscope. It's much easier than the wired one. So we have the illumination system and the viewing system. Very important. Now, these areas are the one we put. How do we put it in our head correctly? This is the part. So how do we put it on directly? Because in the exam, you will be marked how to put it on. So most times you put it on, as I'm putting it on, you make sure the head, this crown is hitting your head, and this back is fastened as comfortable as possible. You don't need to make it so tight that it will give you a headache. This must touch the head. So women with so many hair braids and all that, head gears, will affect the way you put it. So when you go for exam, make sure your hair is cut low so that you can usually wear it the way it should be. So the first thing you've done is to balance it on your head. Make sure this is touching your head. This one is tightened, not too tight. Then the next thing is to set your IPD. You can see me setting. So to set my IPD, okay, I put on the light and I close one eye, I'm looking at my thumb, I exchange to the other eye, and I'm looking at the thumb again, so that I have a binocular vision. Okay, so once I've done that, the next thing is to adjust the ophthalmoscope in a way. You see the lighting, usually I increase it, and I make sure the illumination is a bit off center, that is a bit above the field of view. So I will explain this when we are checking the lectures. So once that is done, patient must always be examined lying down. As you can see, our patient is lying down on the couch. This is the best way to do an indirect ophthalmoscopy. And the pupil must be dilated. And you can see this room is it's not very bright. So we usually examine a dark room. As you can see, then you need your chart. This chart here with color pencils. As you can see, this chart is standard for retina exam. You can see the fundus chart. You can see the side of the eye you are examining. This is the right eye we are going to examine. So the optic nerve is here. So you draw this as if you are looking at a direct ophthalmoscope. The optic nerve is here. The macula is at the center, and you can see the blood vessels. So this is the equator, and this is the ora serrata. So what we are saying is that there is no other features outside here that you must put there. So the equator, the ora serrata. Okay, so everything must be limited to the center of this place. Now we put the name of the patient, you put the date of exam, and your findings can be put down here. Then you get your color code. The blue is a must because we use blue for the vessels. Okay, the red, if there is any hemorrhage, use it. The yellow, if there is exudate, you put it. I'm going to talk more about those other color codes in the lecture. So let's start now. So you need a lens, 20 diopter lens. Now I'm holding a 28 diopter lens. So 28 diopter lens will see a wider field of view. 20 diopter lens will also be standard for everybody. So what do I do when I want to examine? Now you can see that this chart is upside down to the patient but upright to me. Always make sure the chart is upright to you. As the patient is lying down, is upside down to the patient. This is the first limiting step if you must enjoy indirect ophthalmoscopy. As you put the chart here, you don't change it. Whatever you see, you put there. So if I ask a patient, Daddy, I ask the patient to look at his thumb. I want to look at 6 o'clock. Patient is looking down. As patient is looking down, I'm looking at 6 o'clock. And I put, remember this lens too, the line on the lens, this white line should face the patient all the time. That's the plano side of the lens. Okay, this is also marked during the exam. The plano side, where you see a white line on it, you must face the patient. Okay, so once you put it there, I see something, I put it. Okay, so as you can see, I'm looking downstairs, I can see 6 o'clock. Whatever I see, I put here. So in this patient that has a retinal detachment, I can see the edge of the retinal detachment at 6 o'clock. So I'm using my blue pen, because what I saw something like this at 6 o'clock. Okay, remember this is 6 o'clock. Okay, so I see these bullous coming from the optic nerve. So that means this area is detached, as you can see. So whatever you see, you put down directly. So I look down at 6 o'clock, whatever I see, I see. So I want to look at 7. I move the hand of the patient to 7. That's the MR1 here. As he's looking at 7, I've moved my body to 1 o'clock. Initially, I was at 12 for 6. So you must always stand opposite to where you are examining. Okay? As you are seeing it now, I'm looking at 7 o'clock. The retina is there. So all this retinal detachment is extending to 7. I move to 9. So 8 and 9, I'm looking again, retinal detachment is there. So I take the pen, I turn, because all these places are covered. Remember, this is my boundary. So forget this one I'm doing here. So everything must end at ora serrata. So what I'm seeing here, I see all the retina detached in that area. So I move to 10 o'clock. 10 o'clock, yes. Again, it's there. Retina is detached there. Look up. That you look at up superiorly. I can see. Retina is also detached up to 12 o'clock. Okay. So that is one. That is about what we call. I've done like 180 degree, half of the retina. So I put his hand down. I change again. Okay, he's looking at 5 o'clock now, and I'm standing at 11. Okay, because I've looked at 6, so I can still see that edge of retinal detachment here. I can still see the edge there. So I move him to 4 o'clock. I notice that in 4 o'clock, the retina is not detached there. So what do I do? From 4 o'clock, I notice retina is attached here. Okay? And you see? So I move again to 3 o'clock. At 3 o'clock, retina is attached. I look to 2 o'clock. You see my body is moving as I'm moving the hand, my body is moving. As I'm looking at as he's looking at 2 o'clock, I'm standing at 8 o'clock. As he moved to 1 o'clock, I've moved to 7. Now I'm seeing the edge of the RD again. So all these areas attach retina until this one we have drawn before. So we have made the one we are. So this is attached retina. When you see red arch like this, it's telling you retina is attached. Okay? When you see blue, it is detached. So this is how to do it. Let's look at the other eye again. So we start at 6 o'clock again for the left eye. So I'm going to change the paper. This paper, again, look at the chart. I've already drawn the optic nerve here. This is left eye, as is seen with a direct ophthalmoscopy. This chart is upright to me, was inverted to the patient. You see my optic nerve head. I've put the side, left eye. I put the name. I put the date. Okay. So optic nerve is here. Macula is always at the center. You can see the blue lines represent the veins. Okay. So again, this is the equator. The next one is what? Ora serrata. So everything that must be drawn must be within here. So you can see now, to examine the left eye, remember, you don't need to invert anything in your mind. since the paper is already inverted to the patient, everything is reversed. So whatever you see, just put it there. So in this case, patient is looking at 6 o'clock. As he's looking at 6 o'clock, I'm seeing the 6 o'clock. Retina is attached. So retina is attached here at 6 o'clock. I move this hand to 5 o'clock. I move my body to 11 o'clock. I'm always opposite to where it's examining. So retina is attached there. I move it there. Retina is attached there. Okay? I move it there. As I'm moving, you can see my body is moving. This is the movement we want to see in the exam. Okay? See you moving. Okay? Okay? I'll move back a bit. So you capture the whole thing as I'm moving. So when I'm looking at 3 o'clock of patient, I'm standing at 9 o'clock. So you can see patient is looking at 2 o'clock, I'm already at 8 o'clock. Patient is at 12, looking at 12, looking at his thumb, and I'm at 6 o'clock now looking at it. And to see posterior pole, I just want the patient to look in primary position. I put my lens. Once I put my lens, as I'm standing at the head of the patient, I see the disc to my left. The disc is to my left, macula to the center. So as I'm standing here, patient is already reversed to me. The disc is to my left, and the macula is at the center. So you don't need to reverse anything when the patient is lying down. Everything is reversed. So in this patient, the retina is well attached all over. So we use our red line to just say retina is well attached. Okay, no detachment. Remember the other one, we say retina is detached. About more than half of the retina is detached. So the summary of our presentation is that when you want to examine the retina, use an indirect ophthalmoscopy. There's another aspect I want to show us, which is the indentation. This is an indentor. You can also use a cutting. Let me put it here so that I can take a picture of it. Indentor. Okay? Put your hand like this. Indentation. So in order to indent, you can use cutting board too to indent. So what I do, okay, if I want to indent, I put it to my left hand. Okay? I put the lens on my dominant hand. I ask the patient to look at 6 o'clock, just like before. I want to indent 6 o'clock now. Watch how I'm going to indent. I'm going to go through the lid. You see? Through the lid. As he's looking at 6 o'clock, I put gentle pressure. I will see my indentation inside. Because as I press the sclera, there will be a round mold. Especially when you cannot see periphery and you are thinking there's a break in the periphery. Then you use an indentation. That's 6 o'clock. You do that in all the quadrants. Okay? For the superior indentation. Okay? Look at the way I put it through the lid. It's looking at 12 o'clock. My indentation is there, and I can see my indentation inside. All you need is a gentle pressure. You see the sclera being pushed inside. So that is indentation. Well, most time may not be all the cases that you need to do indentation. It is especially when the problem is extreme periphery. You cannot see the oral serrata, and you're thinking the pathology is there. And you do it. So in summary, let's look at what we have discussed today. If you want to do an indirect ophthalmoscopy, patient must be lying down. Dilate the patient. Get an indirect ophthalmoscope. Most time, wireless indirect ophthalmoscope is best. Okay, because you'll be able to move around the patient without the wires disturbing you. And once you put it on your head like this, you adjust that this top band is resting on your head and the one at the back is tightened. So you must adjust this vertical one first before you adjust the horizontal. Okay, the horizontal one, you can see, adjust it. And don't make it too tight. That's not to cause headache. Then the next thing to adjust your IPD. You put on the light of the indirect, look at your thumb, close one eye, make sure you are seeing one thumb, exchange with the other eye, and when you open the two eyes, you are seeing one image. That is to tell you that you are now having binocular single vision. And once you have done that, you take your lens. The lens, usually 20 diopter lens is standard. Okay, but like I'm using here 28 diopter lens, I capture a wider field of view. So in 20 diopter lens on 28, you see that white line. There's a white line at the edge. You can see this white line here at the edge. It's to tell you that's the side that will face the patient. That's the plano side. And you put it towards the patient and you examine. Okay? All these are scored in the exam. Okay? Then you need a chart, like I mentioned. Get a chart ready. Before you even start the exam, get the chart, put the name of the patient, put the side of the eye you are examining, mark out the optic nerve, the macula. Then you remember this is equator and this is oral serrata. So ideally there should be no thing in this past plan. So, and they are labeled according to clock hours. So always use that. And I told you, you must always put it upright to you when you are standing at the head of the patient. And the patient is lying down. That means inverted to the patient. And so you don't need to inverse anything. When you are looking, anything you see will come to you as if you are using a direct ophthalmoscopy. So once the patient looks, this is exactly what you see. And when you move here now, the chart is inverted to you, the patient is upright to you. So you don't need to move the chart again. When you move back here, the chart is inverted, is upright to you, but patient is inverted. So everything is already taken care of. You don't need to be thinking, oh, what I'm seeing down should be up. What is right should be left. So you just examine. And when you are looking at the periphery, when the patient looks down, whatever you see at 6 o'clock, you put it at 6 o'clock. Because the timing, everything is there. So that is summary. So what we are saying is that get an indirect ophthalmoscope, and in the lecture, we'll talk more about what other things we need to do. Thank you very much.